13 million Americans are dealing with something they don't like to talk about, urinary incontinence. And women are twice as likely to deal with it than men. And it only gets more difficult with age. Well, Dr. John Devine from Gulf Coast Medical Group Women's Health is here with some help. Welcome, doctor.
Hi. So
you are a board-certified gynecologist, but you're also specially trained in another area that we haven't often heard of, urogynecology. Explain what that is.
Urogynecology is the new subspecialty of obstetrics and gynecology, and it deals basically with women's pelvic floor health. So it would be what are commonly termed dropped bladders, dropped uterus, urinary and fecal incontinence, pelvic pain, and so those issues mostly.
And this is a topic that I know some people are afraid to talk about, embarrassed to talk about, but there are some important questions that they should be asking their doctors. Absolutely.
I tell my patients these are not life-threatening issues, they're lifestyle-threatening issues. Okay, so once any medical condition disrupts a patient's quality of life, they ought to feel comfortable coming into the physician and asking or inquiring as to, is there anything I can do for this? Many times with urinary incontinence and that, I find women are so worried that they're going to come in and they're going to be told, you need surgery. And that's what they worry about. There's so many things that can be done that are non-surgical in that we as physicians ought to be open and make it comfortable for a woman or a man, if they come in with these issues, to be able to say, I have this problem, what can I do?
Now, I don't have this problem personally, but I'm asking for a friend.
Yes.
If you laugh or if you cough and you have this problem, is there a medication you can take?
No. There's, no, that's what we call stress urinary incontinence. Stress incontinence is the involuntary loss of urine with an increase in abdominal pressure in the absence of a contraction. So that's an anatomic problem. That's where the urethra tube drops. That we have to support. There are non-surgical, there's a little device called a pessary, it's like a diaphragm that works and things. The problem is that it's the loss of the support of that urethra, the pressure. There was a drug that they brought out, but it really didn't pan out. So unfortunately, there's not a medication that treats that. Overactive bladder, urge incontinence, the gotta go, there's medications for that.
Oh, now that we know a little bit more about urogynecology, what are some things that women should look for when they are choosing their specialist or their doctor?
Well, it's important to realize, I mean, anybody can call themselves a urogynecologist. You know, it's, I do urogynecology, I do this, I do that. But those of us who went on, we do now a 3-year subspecialty training. I did a 4-year residency in obstetrics and gynecology, which then makes you a board-certified obstetrician gynecologist once you perform your boards or pass your boards. I went on and did 3 years of subspecialty training, myself with a guy named Don Ostergaard, who started the field of urogynecology about 30 years ago. But that's 3 years of specialty training looking at pelvic floor dysfunction, pelvic floor anatomy, and then dealing with the treatment of urinary incontinence, pelvic pain, sexual dysfunction, fecal incontinence, and then the prolapse and the different things. So really focusing on that as opposed to all of the general things.
Well, one thing I know, we can't delve too much into, but we've heard news recently about the mesh, the surgical mesh that women can use, and there was some controversy. What can you tell us about that versus other surgeries?
Yeah, the mesh, kind of to simplify it, just to think about it, it's like the screen in your window, okay? It's, it looks like fishing line. It's a permanent string that's meshed together. We use that because there's not connective tissue in the pelvic floor in the vaginal vault. So when we would use the native tissue, it would fail. Mesh, unfortunately, is very stiff and it would erode and cause problems. It came out in 1996 for slings to support the urethra. They then came out with these kits for the vagina and had problems. I don't use mesh, never have. I use connective tissue. It actually comes from the leg, comes from cadavers, but it works like a biological mesh, so you don't get that. But the FDA in 2011 came out with a warning stating that if you put this in, physicians should tell patients, and patients should know what the potential risks and benefits are.
So you better go to the right person.
And so the conversation with the doctor is all the more important as we talk about this. Well, thank you so much. It's important information, and people, we want them to know they don't need to be embarrassed to speak with their doctor. For more information, you can visit Gulf Coast Medical Group at one of their locations or find them online. Next, a look at floral fashions from a local designer.
Very interesting, because women don't